Hello everyone, my name is Serena Ricci and I'm presenting our work titled Development of a Mixed Reality System for First Aid Training. We've been using simulation for medical training for a very long time, I would say more than 10 years. And what we've experienced is basically that a low degree of realism affects medical simulation and affects the overall experience. Especially in those cases where the clinical cases are complex, there are multiple figures interacting, or even there are like multiple skills, both manual and soft skills. A low involvement of students reduce the power and benefit of simulation as a teaching tool because students pay like lower attention or less engaged, and this ultimately affects the overall medical training. So in the last year, there are some research group which have been implemented virtual reality application for medical simulation. And if on one hand, virtual reality has the ability and the power to enhance the simulation experience and the realism of the overall experience, on the other hand, virtual reality has a very important and critical drawback, which is the lack of a realistic interaction between the user and the virtual world. And when I'm saying this, I'm thinking about a student who wears his like head-mounted display. He's immersed in a very cool virtual reality. As soon as he needs to perform a manual skill, the interaction is not between the user and the virtual patient, let's say, is not as it would be with a real mannequin. So our idea was basically to combine a virtual reality application with a physical mannequin in a way that the virtual world and the real world are overlapping. This work is a result of the collaboration between anesthesiologists and bioengineers. And the first prototype was specifically dedicated to first aid training, but this approach can be suitable for many medical simulation domains. So basically, this is the setup of our system. On the left, there are the hardware components, and on the right, the software parts. So basically, the hardware components include a mannequin, a virtual reality headset, which is the ACT Vive, and a Leap Motion, which is connected to the ACT Vive and tracks the user hands in real time. For the software part, we use Unity 3D. Unity 3D is one of the most used game engine for virtual reality application. And we also use Blender. Blender is a software for modeling, and we specifically use Blender to model the mannequin and to create it so that the virtual and the real mannequin were as similar as possible. So this is how the physical model looks like. As you can see, here there is the head-mounted display, the ACT Vive. Connected to the ACT Vive, there is the Leap Motion, which tracks the user hands here. And of course, there is a mannequin. The mannequin is equipped with these three trackers. These are part of the ACT system, ACT Vive system, and their function is to basically maintain the overlapping between the virtual and the real mannequin. This means that if the real mannequin moves, the virtual mannequin can move accordingly thanks to the position of the trackers. This is how the virtual model, like these are the main parts of the virtual model. Of course, a mannequin, and the mannequin has been modeled so that the size is the same as the real one. Then there is a scene, the virtual scene. Here I'm reporting a urban setting, which is the first setting we implemented. There are like different settings that can be used. We have right now a hospital setting and an indoor, like a pub setting. And we are also working on other like outdoor scenes such as like beach or a mountain view, and also we are working on a like school-like environment. Other than the mannequin and the scene, we implemented interaction. Interactions are basically animation of the mannequin. and these animations are guided by the user interaction with the mannequin. In particular, our mannequin blinks, and also his gaze can follow the end of the user. In addition, the mannequin breathes, and the breathing can be normal, symmetric, or asymmetric. And also, our mannequin has some wounds, and the wound bleeds. And as soon as the user place his hands close to the wound, the bleeding stops, basically. And these are some examples of interaction. So this is how our simulator works. Again, the user wears is head-mounted display here, and this is what the user sees through the VR headset. This hand is a virtual representation of the real hand, and in fact, the movement of the virtual hand and the movement of the real hand are exactly the same. I don't know if you can see it, but the mannequin breathes, and when the user gets closer to the mannequin, we can actually see the breathing. And if the user moves the real mannequin, the virtual mannequin would move accordingly, basically. So after we have implemented the virtual reality simulator, we wanted to test the system, and we tested the system in two ways. First of all, we tested the accuracy of the system, and what we did was to select 35 points in the real mannequin and compute the distance between these points in the real and in the virtual mannequin. And this is what we call here mean error. And we repeated the same measure for 9 times, and then we averaged the values. And what is visible from this plot here is basically that on 2 out of 3 axes, the maximum error is lower than 2.5 centimeters, while on the y-axis there is an error which is around between 3 and 3.5 centimeters. The minimum error is lower than 1 millimeter, and what's interesting is that 75% of the data have an error, like a distance between the real point and the virtual point on the mannequin is always lower than 1.5 centimeter. Finally, we wanted to assess whether the user enjoyed the simulator we created. And so basically we enrolled, for this part, we enrolled 27 participants, 13 control, meaning people with no medical background, and 14 medical students. We asked the participants to play with our simulator for 10 minutes, and then they had to fill out 2 questionnaires. A simulator sickness questionnaire and an EG group present questionnaire. Result of this part highlighted that no physical discomfort was caused by using the simulator. In general, both controls and medical students enjoyed the simulator from a involvement perspective, and they found it realistic, and the spatial presence was evaluated, assessed positively. Some of the participants found the scenes of the simulator kind of video game-like, but they also reported that this did not affect the overall experience. And finally, what participants liked the most was the possibility to interact with the virtual patient by using their hands. In fact, usually virtual reality applications require to use the trackers, and this would further limit the realism of the interaction. So participants enjoyed using their hands, and they reported that this would increase interaction, sense of presence, and immersivity. I conclude this presentation saying that we are using the same approach to implement a simulator for neonatal resuscitation training, and that we hope we will present it next year at CSAM. I look forward to seeing you at the conference, and I thank you for your time.